Good evening, everyone. My name is Kevin Bergerson, and I am the Patient Education Program Senior Coordinator for the Colon Cancer Alliance. And on behalf of the Certified Patient Navigators and the entire patient support team from the Colon Cancer Alliance, I would like to welcome everyone in attendance. Tonight's webinar is SIRFLOX Microspheres Targeted Radiation, an option for me. This is the 8th in the segment of our Conversations About Colon Cancer webinar series, which we created to provide the opportunity for patients, survivors, caregivers, and family members and healthcare professionals to link with national experts in the colorectal cancer field in an online interactive setting. Naturally, knowing the extent and type of disease a patient may have determines the best treatment path. During this evening's webinar, we will discuss how patients with metastatic colorectal cancer, which has spread to the liver, have several options for treatment. With liver tumors, surgery is the best treatment, but when that is not possible, other treatments should be considered or important because the liver is the most important organ to keep healthy. Understanding the latest advances in SIRFLOX Y90 resin microspheres, targeted radiation therapy can be critical for patients and their doctors to make treatment decisions, particularly if you're facing unresectable metastatic tumors limited to the liver. This webinar will provide a brief overview of SIRFLOX microspheres targeted radiation therapy, as well as a review of the findings of the recent SIRFLOX study presented at the American Society of Clinical Oncology annual meeting. The SIRFLOX study was the first large study to examine the delay and regrowth of liver tumors when selective internal radiation therapy is combined with chemotherapy. Before we get much further into the webinar, I want to let all of you know in attendance that about this time tomorrow, I'll be sending each of you a link with a follow-up email about a survey to this webinar. The Colon Cancer Alliance values your opinion, and we would very much like to hear your honest feedback on how we can make delivery of our webinars better. Please look for that email, and please take that survey when you see it. It's very important that we hear from you because we're trying to make these the best we can. So in other words, help us, and we'll help you. Before we introduce our speaker, a quick note here about questions. We envision all of our webinars to be interactive where attendees can pose questions to our presenter. After our speaker has finished presenting, we may be able to address a few of the questions by attendees during the webinar. Because the number of attendees and because we are tracking these questions, we're only accepting the questions as posted online by the attendees in attendance using the webinar control panel. To submit a question for consideration and possible use, click on the small plus sign located next to the word questions on the webinar control panel located on the right side of your home computer screens. Then type in your question and hit enter. All questions will be asked on a time available basis, so please accept my apologies in advance if your particular question does not get answered. However, all questions that we are unable to get to will be collected and followed up on after the webinar. And with that, we're going to introduce our speaker. Our presenter this evening is Dr. Marwan Faqih, who specializes in gastrointestinal oncology. He is a graduate of the American University of Beirut and completed his residency at Wayne State University. Dr. Faqih specializes in medical oncology and has expertise in colon cancer, colorectal cancer, liver cancer, and metastatic cancer. He is the Gastrointestinal Medical Oncology Director with the City of Hope Comprehensive Cancer Center. And with that, I'm going to turn the webinar over to Dr. Faqih, and it's all yours, Dr. Faqih.
All right, thank you, Kevin. Well, thank you, everybody, for taking the time out of your day and evening to join us today. What I will be talking about today is a new technology or a new modality of treatment for patients with metastatic colorectal cancer, with very exciting data presented at ASCO this year, which is the American Society of Clinical Oncology meeting. It's a yearly meeting in June of every year. So the big question is targeted radiation therapy with SIRFLOX, with yttrium-90 SIRFLOX, an option for patients with metastatic colorectal cancer to the liver. So these are my disclosures. This is a background or an introductory slide to kind of show us where we stand with colorectal cancer in the United States. The good news, as you can see on this slide, is the number of new cases with colon cancer are declining on a yearly basis. And you can see that the incidence of colorectal cancer in the United States has dropped by approximately 30% over the last decade or decade and a half. And with that, there has been an associated decline in the rate of death from colon cancer in the United States. And the credit for that is basically we credit colonoscopies, we credit other modalities of screening such as sigmoidoscopy, and more recently even fecal DNA testing along with testing for what we call occult blood or blood in the stools at the doctor at home, or procedures in the hospital to look for screening such as colonoscopy. So this is all good news. But the problem is that we still have a large number of patients with colon cancer every year in the United States. We have an approximate 136,000 cases of colon cancer on a yearly basis. And despite the decline in the number of new cases of colon cancer, the number of patients dying from colon cancer in the United States is approximately 50,000, and it's been approximately 50,000 over the last 20 years. Now, this contradictory statement with a decline in the number of cases is largely due to the fact that our population is expanding. So even though the rate or the percent of patients developing colorectal cancer has declined out of the overall population, the absolute number of cases with colon cancer continues to be significant, and approximately 50,000 patients are dying with this cancer or with this disease on a yearly basis. And therefore, we need to do more in the treatment of metastatic colorectal cancer. Certainly, we need to improve our screening to prevent more cases, but we know that even with colonoscopies, about 40% of cases are not prevented still. So colonoscopies do not prevent all cases with colon cancer. They're done on an every 10-year basis, and colon cancer will still occur between screening modalities, although less so than without screening. So where does colon cancer stand as far as other cancers? About 1 in 20 individuals in the United States will have colon cancer in their lifetime. And it is the second leading cause of cancer death in the United States. If we look at the stage of disease at presentation, about 20% of patients present with what we call metastatic disease or metastatic colon cancer. That means that at the time the patient is diagnosed with colon cancer, the cancer has already spread either to the liver or to the lungs or to another organ. About 1/3 of patients present with regional disease, and that means that the tumor is localized to the colon, but it may have spread also to some glands around the colon, what we call lymph nodes. And then about also 40% of patients have what we call localized disease, and this is the earliest stage of colon cancer. These are stages 1 or stage 2 disease. It is within the colon or within the rectum, and it has not gone neither to an organ or to any lymph nodes. And those are the patients who have the best prognosis and the lowest risk of recurrence. And as you can see on the right side of this slide, these are the percentages of 5-year survival by stage. And obviously, the individuals who have more advanced disease spread to the lungs, to the liver, to other organs that cannot be resected, those patients have a worse outlook at 5 years, although our numbers have improved, but still less than 20% of those individuals may make it at 5 years. And therefore, we need to tackle that problem, the stage 4 disease problem, especially in individuals where we are not able to achieve a cure at this point, but where we want to live with cancer. So this is a snapshot as to where we are with colorectal cancer as far as presentation and as far as outcome after a presentation with colorectal cancer. So if we look at patients diagnosed with colon cancer in 1 year, it's about 136,000. About 3/4 of those have localized disease, and about 1/4 of those have metastatic disease. Now, if we look at the patients who do not have metastatic disease, do not have a spread to an organ, it's localized or regional. In those patients, obviously, their main treatment is surgery. You basically resect the portion of the colon or rectum that is involved with disease and may receive some form of adjuvant chemotherapy, some form of therapy to try to reduce the risk of recurrence, because there may be microscopic disease left behind that the surgeon cannot see, or that has spread and is beyond identification by imaging studies. If we look at those 70–75% of patients and we follow them up over a course of 5 years, about 1/3 of those patients will have emergence of disease or of cancer in an organ elsewhere. Now, this is really, even though we call this recurrence of colon cancer, this is really not a recurrence. This is pre-existing but was not detectable. And with time, this microscopic cancer that pretty much spread or existed before the original surgery has grown to the point that it becomes detectable. But we still call it recurrence, despite the fact that it's not really a new finding, but it's a new finding potentially on imaging. But these are not new cancers. These are related to the original cancer that has been removed. So if we basically include the overall population with colorectal cancer, about half the patients with a diagnosis of colon cancer either present with a spread to an organ or will develop a spread to an organ after their surgery. So it's a large problem. It's approximately 50–60,000 patients a year, 60,000 patients, maybe a little bit more, will have metastatic disease. Now, if we look at those patients with metastatic disease, 60% of those patients, there's involvement in the liver, 60% or more. So the most common organ to be involved with the spread from colon cancer origin is the liver. And that is natural and expected because the blood that drains from the colon filters through the liver. And that will carry the cancer cells from the colon, and these will lodge in the liver and grow with time. And if we look at the outcome of those patients who have spread to the liver and see what happens to them over a course of time, the rate limiting step in their overall outcome is the liver involvement. And the reason for that is that cancer in the liver grows, and as it grows, it will occupy and destroy normal liver, and the result is that the liver will fail. And since there is really no alternative to liver, there's no dialysis for patients with liver failure, patients with extensive liver involvement may be prone for decompensation of the liver and death from liver failure. And therefore, it's very important if we have a patient with metastatic disease to the liver that we use all the tools available to us, whether it's chemotherapy or other tools, to try to control the disease. And particularly, there is more and more interest now with modalities that implement what we call regional therapy to the liver, such as radioembolization that we will be talking about, in trying to control the liver metastases or the spread of colon cancer to the liver. So when I have a patient with involvement in the liver, we categorize those patients to 3 different categories. If a patient has colon cancer and the disease is only in the liver, the first question I ask myself is this patient presenting with what we call resectable liver metastases. In other words, can I refer this patient to surgery where the surgeon would be able to resect a portion of the liver, specifically the portion that has the metastases, and leave no cancer behind? We know that the liver is resilient. We know that we can remove more than half of the liver, approximately 2/3 of the liver, and that the remaining third of the liver could regenerate and take on the full function of the liver. And therefore, the first question would be, is it only few lesions? Are they localized to one portion of the liver that can be resected or not? And if indeed this is a situation where the disease is resectable, then the patient should undergo surgery. This could be performed either upfront, followed by 6 months of chemo, or with 3 months of chemotherapy, then liver surgery, then 3 months of chemo. And the reason why we want to do that is that the outcome is best in the setting of removal of all visible disease in the liver. Those patients may be cured and have the highest likelihood of being alive at 5 years. More than 50% will be alive at 5 years. Unfortunately, the majority of patients who present with liver metastases have spread beyond resectability. Either there is too many lesions in the liver, so you cannot leave enough cancer-free liver volume to sustain the patient, or they are positioned in a technically difficult area to remove. For example, it's involving the portal vein, which is an important vein for the viability of the liver. So in that event, we are dealing with two situations, either potentially resectable, meaning I cannot resect it now, but if I shrink it enough, it may be resectable. Or we may be dealing with a situation where we feel that this is, no matter what we do, there may be 100 spots in the liver, and even if we shrink them a lot, then it still does not make sense to go in with surgery, because we most certainly will leave cancer behind. And these are the two categories that we would like to discuss today, the potentially resectable and more specifically the non-resectable patients who have significant amount of disease in the liver that we cannot perform surgery. How many of the patients who present with colon cancer have resectable disease? Only 15% of patients who present with metastatic disease to the liver have localized amount of cancer in the liver that is deemed to be amenable for liver surgery. 85% are not. Now, those 85 out of 100 that have quite a bit of disease in the liver or cancer in the liver, if we give them chemotherapy, specifically aggressive chemotherapy, we may render about 10 to 20% of those patients resectable by shrinking their cancer in the liver to the point where the surgery becomes technically feasible. That still leaves us with about 75% of patients with colon cancer that are not amenable to surgery, neither now nor in the future. So how do we treat those patients who are not candidate for surgery? Well, we have many chemotherapy agents that are approved for colorectal cancer. They are clearly effective. It is fair to say that now, with chemotherapy, the longevity of a patient with colon cancer has become 4-fold to 5-fold compared to no treatment, with more than half of the patients surviving beyond 2.5 years and beyond 3 years with chemotherapy for metastatic disease. So clearly we have made progress, but is that sufficient? Obviously not. And so despite the number of drugs that we have, treatment of metastatic colorectal cancer is not curative, and resistance to chemotherapy sets in. And therefore, there is a role to try to control the disease in the liver or the colon cancer that has spread in the liver by intensifying the treatments to the liver. And there are multiple modalities of treatments that can be used to try to control the cancer in the liver by regional therapy. And if I am to divide regional therapy, the main three modalities of treatment right now for regional therapy to the liver are chemoembolization, meaning injecting chemotherapy into the artery that feeds the liver. And since the tumors receive more of their blood supply from the artery of the liver than from the vein of the liver, there is a preferential administration of chemotherapy into these tumors. And that is performed by a strategy called drug-eluting beads with irinotecan, which is basically a chemotherapy a drug called irinotecan that is infused into beads that are injected into the artery of the liver. Now, this modality is used to basically try to shrink tumors within the liver, and there are some studies that have shown that it is effective in shrinking cancer in the liver. It is associated with some side effects after the procedure, such as fever, often requires hospitalization, and there have been some studies that have combined it with chemotherapy and these studies have shown that it is feasible to combine these drug-eluting beads with irinotecan to standard chemotherapy for patients with liver metastases of colon cancer origin. However, that comes at a price of increasing side effects and increasing complications. So despite that there has been some small studies, those studies have been really not practice changing at this point. However, this modality can have some benefit in some patients. The second thing that is commonly used is what we call ablation, and the most common form of that is radiofrequency ablation. Other ablation modalities include microwave ablation. And what this technique is basically placing a small probe into the tumor in the liver and technically frying that tumor in the liver out. Now, this modality is typically effective for smaller tumor, cannot be done on innumerable lesions in the liver. It's typically done only on few lesions in the liver, and is typically done as a complementary modality along with surgery. When a surgeon goes in to resect part of the liver but cannot cut out all the tumors, he would ablate some and cut the rest. The advantage of this modality is that it can be curative as well in the patients who have small and low number of lesions in the liver. And third, which is a modality that is very promising for patients with a large number of lesions in the liver, or with lesions in the liver that are located in areas that prevent surgery. And that technique is radioembolization with yttrium-90. So what is SIRFLOX yttrium-90 microspheres? First, this procedure is FDA approved. It is indicated specifically for patients with colorectal cancer with spread to the liver. And the indication has been based initially on a study that combined that with an infusion of chemotherapy to the liver, and that chemotherapy was FUDR. However, the practice and the use of this yttrium-90 SIRFLOX microsphere modality has expanded since considerably with different backbones of chemotherapy. So what is radioembolization? Basically, this is a technique that takes advantage of the fact that liver tumors receive their blood supply or nutrients through the arteries, and the arteries are basically the blood vessels that deliver the pink blood. And the normal liver does not receive its nutrients and its blood supply predominantly from the arteries, but rather from a vein called the portal vein. So if you inject chemotherapy or if you inject radiation beads into the hepatic, into the liver artery, you will preferentially administer that drug or that resin with radiation into the tumors, and much less so into the normal liver, therefore sparing the normal liver from the side effects. So selective internal radiation is exactly what the name says. You're selectively administering radiation therapy internally into the liver by using these microscopic spheres called SIRFLOX, which carry a form of radiation called yttrium-90. And these very tiny spheres that are not visible to the naked eye float like red blood cells within the blood vessels into the tumors in the liver. And over the course of about 11 days to 14 days, they will emit radiation continuously. Most of that radiation is emitted within the first 11 days. About 94–95% of the radiation is gone. And there will be millions and millions of these beads now localized within these tumors. And pretty much every few cancer cells or every few hundred cancer cells, there will be bead emitting radiation therapy. And the radiation is emitted from each bead at a distance of no more than 1/10 of an inch, which actually makes this procedure very safe and does not require any isolation for patients receiving this form of radiation, despite the fact that it's continuing to emit radiation for approximately up to 2 weeks. So the indication for the SIRFLOX, yttrium-90 SIRFLOX, is basically metastatic colon cancer to the liver. And what we will follow next is the data supporting the use of this modality of treatment and what to expect with microspheres with these resin beads with yttrium-90. So we covered this slide, and the only thing that I would like to add here is that the amount of radiation that is emitted with this modality is quite intense. Actually, if you compare the amount of radiation that you can get within the tumor by using these microspheres, these resin beads that emit yttrium-90, it can be up to 40 times higher than what a patient can receive by using regular radiation techniques, what we call external beam radiation. The nice thing about this procedure is also that it is an outpatient procedure. Yes, it does require that the patient undergoes certain tests to find out if they are eligible for this kind of treatment or not. However, once deemed eligible, these patients will receive this treatment by interventional radiology, and they will be going home on the same day. So what are the side effects of SIRFLOX? As I said, this is an outpatient procedure. It basically requires catheterization of the femoral artery. So the interventional radiologist will insert a small catheter into the groin, and then that catheter is tunneled all the way through into the artery that feeds the liver, and then the microspheres are injected into the liver. The patient then subsequently goes home. The most common side effects that we see using this technique is that patients may feel tired for about a week or so. The fatigue is not limiting. These patients are able to go out and about and do their perform all their daily activities, but they do feel tired for about a week or two. Occasionally, a patient may have a little bit fever, but as you can see, only 2% of patients will have fever after the procedures. Few patients, 9%, will have nausea, but it's mild to moderate. And severe vomiting is only about 1% of patients. There's often mild discomfort in about 10 to 12% of patients in the right upper quadrant where the liver is after the radiation, but this is easy to control with oral pain medications, and it's not typically severe. The more serious side effect that we experience or see with radioembolization with SIRFLOX microspheres is the possibility of developing a stomach ulcer. The original data had suggested that about 5 out of 100 patients who receive radioembolization with SIRFLOX will have an ulceration in the stomach. And this may cause significant discomfort and pain and may cause the need or may require treatment. Now, as there has been more experience with using SIRFLOX microspheres, the rate of stomach ulcers have decreased significantly and now are estimated to be closer to about 1 or 2% of patients. The other side effect that can be a result of selective internal radiation with microspheres to the liver is the possibility of radiation-induced inflammation to the liver. And the end result may be an increase in liver enzymes, and in general that is reversible. However, rarely, but surely, a patient can have liver failure in association with SIRFLOX microspheres. And that has been estimated to be less than 1% of patients. And certainly now with better patient selection, this has been becoming more and more of a rare side effect. So who is the best candidate for radioembolization, and who could be candidate for radioembolization with microspheres? As we said earlier, this is a technique that provides treatment predominantly to the liver. These beads will not go outside the liver. They will lodge within the tumors in the liver. So obviously a patient with metastatic colon cancer who has extensive amount of cancer outside their liver will not benefit much from this procedure because you're controlling the liver, but you're not controlling the extensive amount of disease outside the liver. So this procedure is really best for patients who have what we call only metastasis to the liver or predominantly to the liver. So those patients who have only a few small tumors outside the liver could benefit from this procedure because you're controlling their liver disease. But those patients who have massive amount of disease outside the liver will not benefit. Second, the patient should have a good performance status, should be able to take care of himself or herself, should be up and about at least half of the time during the day. And that's what we call good performance status. The liver function should be good, and the patient should be expected to be able to weather the procedure and go on for several months without therapy. One test that is very important to test is called bilirubin, and that is also a liver function test. Those patients who are jaundiced or have high bilirubin should never receive this therapy. So now I'm going to share with you some of the data that is out there that supports the use of radioembolization with SIRFLOX microspheres in patients with metastatic colorectal cancer. As I said earlier, this is not a new modality of treatment. However, the supporting evidence for its use has emerged more and more in the last few years, and specifically with a study called SIRFLOX that we will be discussing after a few minutes. But even before that study has reported, there has been several studies that have looked at radioembolization with SIRFLOX in patients with colorectal liver metastases. You can see on this slide a study by Gray looking at chemotherapy at that time, with chemotherapy given directly to the liver called FUDR versus the same chemotherapy FUDR plus the SIRFLOX microspheres yttrium-90 radiation. So they received the same backbone of chemo, and it was regional to the liver, but only half the patients got on top of the regional chemotherapy, regional radiation. And the response rate tripled from 18% to 44% on that study. And the disease control in the liver, as you can see on the study, improved by 6 months, 9.7 months with chemo alone, up to 16 months for chemo plus radiation. So that is a small study. It's 34 versus 36 patients, but it was the first proof of principle that when you give internal radiation to the liver, you will shrink the tumors in the liver more, and you will control the liver for a longer period of time, and therefore this will translate in a better longevity, as you can see on that study, improvement in overall survival from 18 months to 23, 24 months. Now this was 2001. And since there had been a couple other studies that have shown the same with intravenous chemotherapy, again, significant improvement in shrinkage in the liver, significant improvement in disease control in the liver in this particular small study by Van Hazel. The time to progression or increase in size in the tumors in the liver was about 18.6 months. So all this interesting data that supported the use of radiation, selective radiation, or selective internal radiation to the liver has led to the conduct of a very large study called the SIRFLOX study. And this study is what we call a randomized phase 3 clinical trial. It's a proof of principle study that is conducted to try to prove a principle and to change the standard of care. And the question on this study was, if we look at modern chemotherapy, can we add selective internal radiation with SIRFLOX microspheres with these resin beads? And if we add the resin beads to this backbone of chemotherapy, to standard chemotherapy, can we improve the time to progression? Can we delay the time until which the tumors start growing again? And the backbone of chemotherapy that was used on this study is called FOLFOX. And FOLFOX is 5-FU, oxaliplatin, and leucovorin. And that is a chemotherapy that's used in 70% of the patients in the first-line treatment of metastatic colorectal cancer in the United States. So half the patients received FOLFOX, and half the patients received FOLFOX plus the microspheres with SIRFLOX. The patients were allowed also to receive another drug called Avastin or bevacizumab, which is a drug that attacks the blood vessels within the tumor and delays also progression. Hello? I'm hearing some background noise. All right. Can somebody mute their phone, because it's thank you. So this study randomized 530 patients. Half the patients got FOLFOX and half the patients got FOLFOX plus microspheres. This was an international study. It was conducted in Europe, in the United States, in Israel, Australia, and New Zealand. And the selection of patients was patients who have what we call liver-predominant disease or disease only in the liver. Right? So those who had disease that was called liver-predominant had few spots only in the lungs that were very small, typically about a third of an inch or smaller. So they were still predominantly liver metastases. And the primary endpoint was progression-free survival. That's the point at which a patient's disease starts progressing on treatment, meaning becomes resistant to treatment. So as far as to who are the patients who were enrolled, those patients also should have had a good performance status, obviously older than 18, and have not previously received chemotherapy for metastatic disease. And that's why this is called the first-line chemotherapy. So this is the first chemotherapy step after diagnosis of metastatic disease or spread to the liver or to other organs. The patients who were excluded were patients who had prior radiation to the upper abdomen, because those patients would have had some radiation to the liver that may make the liver not able to withstand more radiation, and those patients who had indications for chemotherapy such as nerve damage or other toxicities. Now, it's important here to note that even though the primary endpoint of this study was any growth in a patient or what we call progression-free survival, there were secondary endpoints, meaning there were other goals that the study wanted to pursue and to prove that were beneficial. Particularly, is this modality of treatment able to control the disease in the liver? And therefore, it was important to have a specific endpoint of what we call progression-free survival in the liver, meaning we're using now radiation selectively in the liver to try to shrink the tumors, and there's very little disease outside the liver, and we know that the liver is the rate-limiting step. So what if the same patient developed 1 or 2 new spots on the lungs? That does not necessarily mean that this treatment didn't benefit the patient if his tumors in the liver shrunk by 50%. And therefore, it was important to try to separate the benefit in the liver from the overall benefit, because these patients had predominant involvement in the liver, and that was going to be their rate-limiting step. Another endpoint was the shrinkage, how much shrinkage, and that's what we call objective response rate, and the safety, as well as did this procedure help in getting the patients to a liver resection. So now if we look at the primary endpoint on this study, which is time to growth of cancer on treatment anywhere in the body, not just in the liver, you can see that this treatment, the addition of radiation to the liver, did not make a big difference. The average time to controlling the whole disease in the body was 10.2 months in the patients receiving chemotherapy, versus 10.7 for those who got chemotherapy plus selective internal radiation. This was not statistically different. And therefore, from that perspective, the primary goal of that study, or the primary endpoint, was really not met. However, what was important in this study is that when they looked at the time for the tumors in the liver to grow, there was a very substantial difference in those who received internal radiation, selective internal radiation to the liver, plus chemotherapy in comparison to chemotherapy alone. If you look at the chemotherapy group alone, the average control, the median time to progression, was 12.6 months in the liver. For those who got selective internal radiation to the liver plus chemo, the median time to growth within the liver was 20.5 months. And that is a substantial difference of about 8 months. And that surpasses anything we've seen with additional agents or stacking up additional drugs to chemotherapy. What does this translate into? It translates into a 31% reduction in risk of progression in the liver. Now, if you look at the amount of shrinkage of the tumors in the liver, you can see that with chemotherapy alone, only 2% of patients had complete disappearance. So it's not just 50% shrinkage or more, complete disappearance of the tumors in the liver. If you look at those who got the selective internal radiation with SIRFLOX microspheres, it tripled to 6%. If you look at what we call response rate, and the definition of response rate scientifically is shrinkage by more than 50%. 69% of patients who had chemotherapy had shrinkage in the tumors in the liver by more than 50% versus 79% for those who got the radiation plus chemo. So it added another 10% of patients with major reduction in the tumors in the liver. As far as the safety, we do expect some additional side effects to occur when we add radiation to chemotherapy. Specifically, there was more decline in the number of white blood cells. There was a more decline in the number of platelets. And these, however, led to a very modest increase in the risk of an infection. So 2% of patients who got chemotherapy had fever with decrease in white blood cells, and 6% of those who got the radiation plus the chemo had fever in the setting of low white blood cells. As far as to serious side effects that we expect or we see with radioembolization to the liver with SIRFLOX, remember we talked earlier about stomach ulcers. On this particular study, it was 3.7%. The liver failure rate was 1.2% related to radiation. So what are the conclusions from this study? Number one, that the addition of selective internal radiation with SIRFLOX yttrium-90 to chemotherapy, the addition to chemotherapy, has resulted in improvement of about 7.9 months in the median progression-free survival, meaning delaying the time for the cancer to grow in the liver by approximately 8 months compared to chemotherapy alone. This is approximately a third improvement, or a 31% reduction in the risk of progressing in the liver. There was a significant improvement in complete responses in the liver from 2% to 6%, and improvement in shrinkage rate in the liver. So now I'm going to take you as to how we have applied the use of radioembolization with SIRFLOX, Microspheres, yttrium-90 in our patients with metastatic colorectal cancer, and take you through its use across different lines of treatment. So the study that I just showed you was the SIRFLOX study, which was a first-line chemotherapy study, meaning these are patients who present with spread to the liver and had not received any chemotherapy to treat their liver previously. But the truth is we can also use radioembolization with SIRFLOX, Microspheres in the second-line treatment, as well as in patients who have metastases or spread to the liver who have received chemotherapy and where the chemotherapy is no longer working. So in the first-line setting, we have discussed the data with SIRFLOX, on SIRFLOX, and I'm going to show you a few examples of how we have used it in our practice in a patient population that is able to receive chemotherapy and in a patient population that cannot tolerate chemotherapy. So this first slide is of a patient who is 73 years of age, who presented with colon cancer in the right colon, and as you can see on this slide, a very large mass in the right liver. This is in July of 2013. The patient actually presented to us in January. We treated him in January 2013 with chemotherapy with FOLFOX, and then after 3-4 months, we maintained him on 5-FU-leucovorin Avastin, what we call maintenance therapy. And unfortunately, as you can see on this graph, his CEA started going up from 750 up to 1700. And at that time, we did the CT scan in July, and we have seen that the right hepatic mass had increased in size at that time compared to prior scans. This patient did not tolerate very intensive chemotherapy well, and we did not wish at that point to change his backbone of treatment since he had other disease outside the liver that was still under control with maintenance chemotherapy. So we ended up using SIRFLOX with selective internal radiation to the liver, and you can see a significant improvement after 2 months in the size of that hepatic mass from before to after, despite the fact that we did not change the chemotherapy. And indeed, it took about 14 months for this patient before we had to switch his chemotherapy backbone. In other words, the nice thing about this treatment in this particular patient is that we kept him on a mild chemo that did not interfere with his quality of life, and we were able to control his liver disease by using the selective internal radiation therapy with SIRFLOX. This is another example of another patient, again 73 years of age, who had multiple lesions in the liver, and was also suffering actually from lymphoma as well besides colon cancer. And this patient again was treated with chemotherapy, initially with an induction type of chemotherapy, meaning multiple drugs, and then we kept him on maintenance chemotherapy, which he was tolerating very well with 5-FU and Avastin. And in April, he started, between February and April, we started seeing a rise in his tumor marker that you can see here on the graph within the slide. His numbers went up to about 35, and in conjunction with that, we had seen as you can see on the CT, some new spots in the liver and slight increase in pre-existing spots in the liver. So in this patient, again, we used radioembolization with SIRFLOX. We combined it with FOLFOX times 1 cycle, just like the SIRFLOX study. And you can see a very steep decline in the tumor marker after April, right after the SIRFLOX were given. And again, this patient was able to stay with the same maintenance chemotherapy with full control of the liver for an additional 6 to 8 months before we had to switch chemotherapy on him, without any decline in performance status. So these are examples where we have integrated radioembolization in the maintenance treatment of our patients with metastatic colon cancer to the liver that were not deemed resectable, and without really stacking on more chemotherapy that is associated with more toxicities. This is the same patient, and you can see that after radioembolization, there's no growth at all in that lesion between February and July of 2014. It remained stable. And this patient took more than 15 months before he progressed. Now, this is another patient who's 77 years of age, who is relatively frail, who had about 10 or 12 lesions scattered in the liver. Her tumor started in the rectum, and we treated her for about 10 months with very mild chemotherapy, 5-fluorouracil and Avastin. And even with that mild chemotherapy, she was intolerant to treatment, and her disease remained in the liver. So we treated her right lobe of the liver first with radioembolization with SIRFLOX, and you can see what lights up on this scan on the March 2014, these orange areas are active tumor in the liver, and those orange spots disappeared after 2 months from radioembolization. Now, since we treated only her right lobe initially, unfortunately, the spots on the left lobe grew and started lighting up. And that is natural because there was no selective radiation to the left lobe. And in this case, what we did, this is now the left lobe. You can see that there is about 4 or 5 spots on the left lobe in May 2014. She received the second dose of radioembolization with SIRFLOX to the left lobe of the liver, and 2 months later, completely gone. And this patient's PET scan continued to be normal with no uptake in the liver for more than 10 months after. So here you see a situation where the patient is intolerant to treatment. Now we controlled her disease in the liver, and we did not have to go back to chemotherapy. Indeed, in this patient, we eventually had to resume chemotherapy because her tumor in the pelvis grew back, but not in the liver. So we can use this also in the second-line treatment, meaning in patients who had 1 line of therapy. This is a patient who had a heart attack with 5-FU and therefore had to receive a combination called IROX in the first-line treatment as a therapy. And eventually, after several months, his disease progressed. And so in the second-line treatment, we gave him SIRFLOX, Microspheres. And you can see between July 2013, these spots, these round dark gray spots within the liver are much fainter in response to treatment. In this particular case, the treatment worked for 6 months in controlling the liver. It is also important to note that this is a very effective modality in patients who have failed all active chemotherapy, what we call refractory colon cancer. So this is an example of a 52-year-old patient who presented to me 2 years ago. And this is a July 2013 scan on the left. And this patient was actually referred to us for what we call phase 1 clinical trials, meaning there was no options of therapy for this patient, and he was seeking experimental treatment. And when we looked at his scans, his disease was limited in the liver, and we felt that he would benefit from, rather than a phase 1 study, go to receive SIRFLOX, Microspheres to the liver. And you can see that 2 months later, these dark spots are fading away and getting even smaller 4 months later from doing SIRFLOX radioembolization. This was done in September, and you can see on the graphic below the CT scans that the CA declined from about 1,200, so 1,200, all the way to almost undetectable. And this patient benefited from this therapy for approximately 1 year. And so remember, we did the treatment back around, August of 2013 or so, and now this is back in this is March 2014. There was slight regrowth within the liver, so this is about 9 months or 10 months later. And what we did in this patient is we used the same treatment over again. Now, radioembolization can be used, but not indefinitely, because there's a certain amount of tolerance to radiation in the liver. And indeed, this you can use it 2 times, sometimes 3 times if it's for a small portion of the liver, sometimes more than 2 times. And in this patient, we had a decline again in CA. So you can see here where we started, the tumor marker tanked all the way to normal. And around, April, May of 2014, started going back again and retreated, and again going down again. This patient is still alive, and we're following him 2 years later after he was referred for a phase 1 clinical trial and is doing relatively well. So I hope these case studies show you that this treatment can be used in the first line and the second line, and in patients who have failed chemotherapy, all chemotherapy treatments, and that it is effective in shrinking cancer in the liver. I think now there's clear evidence to support from clinical trials that this is a modality of treatment that can be used across different lines of treatment for colorectal cancer. It is done on an outpatient, in an outpatient setting with acceptable side effect profile. And it is certainly a very effective tool in the management of metastatic disease to the liver. In patients with metastatic spread to the liver where surgery is possible, then surgery should be done. This treatment with SIRFLOX should be limited to patients with metastatic disease to the liver that are not candidate for surgical intervention. And we discussed 3 different treatments to the liver: radioembolization, chemoembolizations with DBRE, drug-eluting beads, irinotecan, as well as we've talked about radiofrequency ablation earlier. There's also another modality called hepatic arterial infusion, which is directing infusion in the liver. Radioembolization, among the 3 listed on this slide, DBRE and hepatic arterial infusion, is the least associated with side effect and the most tolerable, and at this point has one of the most robust data sets based on the SIRFLOX clinical trial, and therefore is a favored strategy in non-resectable chemo-resistant liver-limited disease, or based on the recent data with SIRFLOX, could be certainly integrated in the first-line setting as well in selected patient population. The treatment with SIRFLOX should be in a multidisciplinary team setting where a discussion between the interventional radiologist, medical oncologist, and surgeon is ongoing. So I hope this presentation was helpful to you, and I'm happy to take any questions.
Thank you, Dr. Fakih. We are very grateful for your expertise and for your presentation here. That was some fantastic information. At this time, we're going to ask our presenter to respond to a few of your questions. And the first one comes to us from Mike. Mike would like to know, I have been to 2 different doctors who disagree on treatment after my chemo, FOLFOX. One recommends RFA first, and then potentially Y90 later. And the other one recommends Y90 only. Which seems like the most logical approach to radiation?
Okay, so I want to stay away from individual cases, but I will make some general comments, because the truth is the answer depends on the number of lesions in the liver and the gentleman that emailed this question, the location of these lesions, the number of these lesions, and the size of these lesions. I think surgery has gone a long way nowadays, and the first question will be: is this disease limited to the liver only? The second question will be, if it is limited to the liver, even if it is 8 or 10 spots or even 12 spots, can they be removed? And if they are not removable, can chemotherapy shrink it to the point that you can remove it? In certain settings, we can only remove 3 or 4 lesions, but at the same time when the surgery is being performed, the surgeon, and sometimes with assistance by the interventional radiologist, can actually burn out completely an additional 5 or 6 or even 7 lesions. And so therefore, if I have a patient who, even if they have 8 or 10 lesions, if I can shrink those to the point where they can be resected or ablated, then I think the answer would be I would favor chemotherapy first, get some maximum shrinkage, and then proceed with curative intent surgery. If it is clearly found on a multidisciplinary evaluation by a team of experts in this area, including a surgeon, that this patient is not going to be a surgery candidate, then the question and the tumors cannot be ablated completely, then I think radioembolization would certainly be a very reasonable option in that setting. As far as the role of radioembolization with SIRFLOX as a neoadjuvant format, meaning a treatment modality to shrink tumors for the purpose of surgery, I think we have more to learn. The study with SIRFLOX hopefully will add some information, but remember that study was in patients who were not to receive surgery. A small portion of patients underwent surgery eventually, and we need longer follow-up on those patients. So I apologize, but I cannot answer the question directly as far as it relates to you, because I don't know your case. But I would always say that if there is a chance to get you to a no measurable disease surgically, where all the tumors can be either fried or burned with ablation and surgery, that would be the most sensible thing to do, because that's the best way to shoot for a potential cure.
Can you clarify the minimal effects to the surrounding tissue one more time?
Right. So it's when because these beads float in the arterial system and very little arterial blood supplies the normal liver, there is very little amount of radiation that scatters to the normal liver. But that's not zero, okay? So probably about 90 to 95% or so of the radiation will go to the tumors, but there's still some radiation that goes to the normal liver. And that's why there is a lifelong limit as to how much selective internal radiation you can do to a liver. And that's why there is occasionally patients who have weak livers are not candidate for this procedure. That's why we have these criteria for bilirubin of less than 2. In general, most of the radiation will go to the tumors, but there's still some scatter effect to the normal liver.
Very good. Got 2 questions from Sherry now. She would like to know, is there a maximum percentage of liver replacement by tumor that precluded treatment with radioembolization? The other question is, do you have any thoughts on why overall survival was not impacted in SIRFLOX despite good responses in the liver?
Right, great question. So for the first question, what matters most is really the liver function. So even if there is a significant percentage involvement in the liver, that is not a contraindication for radioembolization. There are some data, but it's not really very good or very strong data suggesting that extensive liver involvement may be associated with less robust improvement. However, I don't think this is validated enough to exclude from patients from this modality, especially in patients who really don't have an option of chemotherapy in that setting or are intolerant to chemotherapy. As far as to the second question, I think it's important to differentiate the difference between progression-free survival and overall survival. And so if you recollect what I had said earlier, is that the primary endpoint of the study was to look at the duration of disease control in the liver and outside the liver combined together. In that particular setting, you are including 60% of the patients who went on the study had disease outside the liver, and those patients received a little bit lower dose of chemotherapy in the first 2 months of treatment because they got the radioembolization, so they had to decrease their chemo dose. So it is likely that some patients were more likely to have some growth or increased growth compared to the full dose of chemo in the cohort that had some spots in the lungs, or in the cohort that still had their colon tumor unresected or rectal tumor unresected when they went into the study. So that is called progression-free survival, meaning the time until which the patient has not progressed. The overall survival, which basically reflects if the patient is alive or not, has not been reported yet. So we do not know what is the impact of radioembolization on overall survival as of yet. And the reason for that is that there are 2 other studies that are ongoing that mirror the SIRFLOX study that we have discussed today. And when those 2 studies are complete, then we have a large enough number of patients to be able to comment on the merits of this modality in improving longevity of patients. So, it is still unknown if the improvement in the liver will translate in improving survival. It is expected that when somebody's disease is predominantly in the liver, and since the liver is such a vital organ for survival, that if you delay the time of disease progression in the liver, that indeed may impact the overall survival, but we won't be able to say till we see that data. And I think that's at least now 1.5 years from today to 2 years to know that.
Our last question will come from Deborah, and this has to be real quick because we're running out of time. I'm going to have to paraphrase here. She's recalling that patients with neuropathy would not be good candidates for treatment. Would that include someone who developed neuropathy as a result of oxaliplatin from FOLFOX treatment?
Right. So let me clarify. SIRFLOX itself, the radioembolization has no impact on neuropathy. So somebody can have grade 3 neuropathy and have even some difficulty walking from bad neuropathy from oxaliplatin and can get SIRFLOX without any issue. This was a criteria for the study that was conducted because you're giving those patients oxaliplatin with the radioembolization. So you're not going to, if somebody has severe nerve damage, you don't want to keep giving oxaliplatin, and therefore you cannot put them on an oxaliplatin-based study. But the radiation component has nothing to do with neuropathy, and a patient who has neuropathy can clearly, without an issue, have radioembolization.
Thank you for that clarification. That was good. I was glad we were able to sneak that last question in. At this time, I'd like to thank everyone for their questions, but we are out of time for this evening. And on behalf of Colon Cancer Alliance and all of the attendees, I would very much like to thank you, Dr. Faki, for your time this evening. Thank you, sir. That was an amazing presentation. Your expertise and time was greatly appreciated. Any closing thoughts at this time, sir?
No, thank you very much, Kevin, and thank you for everybody for joining us tonight. And if there are any other questions, Kevin, in the future, please feel free to email me. I'm happy to respond.
Absolutely. Thank you again. And before we go, don't forget to join us, everybody, for our next month webinar. It runs in the family, colon cancer and genetics. About 1 in 4 patients have a family history of colon cancer that could suggest a genetic or hereditary factor. Do you know your family's health history? Join us to learn how knowing your family history can make a big difference in preventing and treating colon cancer. This webinar will cover everything from what it means to have a cancer family history to the importance of talking about your healthcare provider about your cancer family history. We'll also learn about how understanding an inherited genetic mutation diagnosis means for those specifically with colon cancer family history. Look for that registration to open up on our website soon. As a reminder, look for our webinar tomorrow, our webinar survey tomorrow. Please fill that out. We're looking for your feedback to make our webinars better. And thank you, everyone, for attending this evening's webinar. As a reminder, this webinar has been recorded and will be available for viewing within a week of the broadcast at our ccalliance.org/webinars online. That's where we park it. In addition, we'll be posting the top 5 takeaways and other related information to our blog check out our blog at ccalliance.org/blog. And of course, if you'd like to share any comments regarding the webinar, in addition to filling out that survey tomorrow, please feel free to email me anytime at kbergerson@ccalliance.org. On behalf of the Colon Cancer Alliance and tonight's presenter, I would like to once again thank everyone for attending and thank our presenter, Dr. Faki, and I hope everyone found it informative and value-added. Good evening, and take care, everyone, and thanks for coming.